Yes, sir.
Yes,
First,
sir.
we have Dr. Prabu Bhaskaran, sir, from Arvind Eye Hospital, Chennai. He's an editorial board member, IJO and TNOA journals. Keen interest on ophthalmic innovations and translational research. He has over 40 indexed publications to his merit, and he's innovator of the novel surgical technique in SFIOL, also known as the XNet or extraocular needle guided haptic insertion technique. And sir has also won the ASCRS 2017 Film Festival Award and the Arvind Inspiring Innovator Award in 2020. Over to Prabu Bhaskaran, sir.
Prabhu,
thank you.
All yours.
Thank you for the kind intro. Yeah, I would like to thank TNOA for this wonderful opportunity. So let me share my screen.
5 minutes is the presentation.
Yeah, shall I run my video?
Yes.
Yeah. So S-Fix or suture guided haptic fixation technique is a new technique device that we have developed in collaboration with Aurolab to simplify the haptic fixation step in SFL surgeries. So the device goes like this. It has got a cannulated polyamide tube to which we have connected 50 nylon thread, as you can see here, and it is crimped into a 380 degree micron suture needle. So this is an animation video. As you can see, the first step is docking. You dock the haptic into the polyamide tube. Then you push it inside intraocularly. Then you take a suture bite of 2 to 3 mm over the sclera at 50% thickness, as you can see here. So first step is docking, second step is push intraocularly, and third step is a suture bite. So after that, you pull. That's the fourth step. You pull the thread gently. As you can see, you keep pulling the thread gently. The polyamide tube plus the haptic complex follows the track, suture track created by the device, and it gets into it. Then further pull will disengage, and then the haptic is fixed. So repeat the same steps on the other side. So that's how the haptics are fixed in SFL surgeries. This is a new concept we have come up with. It's a surgical video. As you can see, this is the first step. Dock the haptic into the polyamide tube. So 4 mm of docking. You dock till you touch the suture filled portion of the device. So after that, you push it inside intraocularly. This is the second step. Completely push it inside. You don't have to worry about haptic slip in this. So this is the second step. You do it completely. And then the third step is a suture bite. This is a 380 micron customized spatulated needle that we have designed. So the important thing is you start the suture track from the point of sclerotomy or very close to it, and then go around 2 to 3 mm over the sclera at 50% thickness depth. And then after you exit, pull it. That's a fourth step. You keep pulling it, pull the suture slowly. So as you can see, it's very important that you ensure that the entire polyamide tube is intraocular, because a polyamide tube doesn't, it's not that flexible like a suture thread. So it has to be inside. Then you pull. As you can see, now you are pulling. The polyamide tube with the haptic will follow the suture track that has been created by the device. So it's completely transconjunctival. You don't need any specialized instrument to forceps to fix the haptic. If you feel there is excess chemosis, you can cut open the conjunctiva, but most of the times it's not needed. So as you can see now, if a bit of haptic is seen extraocularly, it's okay, not to worry. You can always push it back using McPherson forceps, and also it gives some scope for you to titrate the IOL centration is taken care. So repeat the steps. As I said, there are 4 steps. First is docking. So it's important that you dock till you touch the suture filled portion of the polyamide tube. The yellow thing is the polyamide tube as I'm talking. So it has got cannulated portion of 4 mm and suture filled portion 4 mm. So you dock it till you touch the suture filled portion. This is the second step. You push it completely inside, completely intraocular. The haptic will not slip. There is no space inside the eye for it to slip. And third step is a suture track. You start from the point of sclerotomy or very close to it. go around 2 to 3 mm of the sclera and exit. This is the 380 micron spatulated needle that we have designed. So the fourth step is to pull the thread. So as you pull the thread gently, the polyimide tube and the haptic will follow easily without any resistance. We have designed this in such a way that the entire resistance during this step will be faced by the suture thread and the polyimide tube junction. That's the most crucial junction. That's a bottleneck that we have taken care that it doesn't give way. Whereas the haptic and the polyimide tube junction doesn't face any resistance throughout. So as you can see now, the polyimide tube is going to get disengaged. This disengagement is facilitated by the counter traction given by the intraocular lens per se from inside. So as you can see, a little bit of haptic is seen. You can always push it inside. On the other side, now the haptics are fixed and the IOL is centered. Thank you.
Yeah, I think we should go to the panelists, Prasanna. Frankly speaking, Prabhu, I couldn't understand.
It's a very simple project. It's very nicely they're done. The fixation part only they are taken care. This is not the entire intraocular lens.
Yes,
It's
yes,
fixation part. The fixation of the haptic is of making a track. It's taking care. It's a nice technique as you. It's addition to the scleral fixation technique, like a glue IOL we are doing. For that it's a little modification of glue IOL of haptic fixation.
Mohan, can I ask something?
Yeah, please. Yeah, all the panelists.
Yeah, I really like the technique. It was, I thought, made very simple. Only one question is why are you so confident that the haptic will never slip out of it?
Sir, this concern was there with us right from the beginning. We have been doing this for the past 3 years, and till now I have not come across this situation. And we've done various experiments. We have realized that if you do 4 mm of docking, we recommend 4 mm of docking. As I said, the polyimide tube is 8 mm, 4 mm is cannulated, and 4 mm is suture filled. So if we dock for 8 mm, there is no way that it can slip inside there is no scope. There is already an IOL and then haptic. There's no, and there is nothing that can pull the haptic. So the force is only outside pulling. So I'm sure, quite confident that this will not slip inside. As I said, the bottleneck is the suture thread and the polyimide junction. That has to be very strong. So that initially we had initial days a few years ago, we had issues in that giving way in wet lab and all that. We realized that we need adequate gluing, 4 mm. So now we recommend 4 mm of gluing. So with this specifications, the safety is quite ensured.
So this is manufactured by whom and what's the commercial?
So this is not at commercial, so we are very close to it. We are working with Oro Labs. I'm just done with the trials, and we are very soon we are going to launch this.
Just to add to another answer, Kumar and Mohan Rajan sir. Prabhu, what's the wall thickness of the polyimide tube?
Sir, it's internally it's around.
No, I'm not asking for internal diameter. I'm asking for the thickness of the wall, because it's a snug fit internally, isn't it?
Yes, snug fit internally. Yeah.
Because the wall thickness must be very thin. It must be very thin because polyimide is a very tough material.
Yes, it's not flexible. It's not very. That's why I said it has to be intraocular.
So to answer Kumar, actually, if you're using a needle track, a 27 gauge or a 26 gauge needle, the wall thickness of the needle, of the hypodermic needle, is actually a lot more than the polyimide tube over here. Okay, so the polyimide tube is one of the toughest plastics on earth, because I use polyimide for my BX. So I'm familiar with that. So the wall thickness is it's so thin that once you take it out, the tract actually fits quite snugly. The haptic fits quite snugly into the tract. So that is one of the reasons it will stay. Instead, if you use a needle, you're likely to leave a tract which is slightly larger than the diameter of the haptic, then the slippage chances are higher. Am I right, Prabu?
True, absolutely.
Yeah.
I'd like to add one more point. I realized that the haptic is curved and then the polyamide tube is straight. So if you dock the curved thing into a straight thing, the fit is going to be it's going to be snug fit. So we have not really come across such an issue.
And do you recommend a specific IOL with not a modified J or a modified C haptic? Because some of these 3-piece haptics are large because they're modified C design, and some of the 3-piece haptics are modified J design. So the C designs have larger haptic coverage and a larger volume that comes out. So do you recommend in this technique that this is a specific 3-piece design?
Yes, sir. I think C will be better always. Most of the times we use C for SFILs. I think J is not probably preferred.
Nice.
Venkatesh,
Yeah, Prabu, because I've been following this technique for quite some time now. I'm able to really perceive how it works.
Venkatesh, can you just explain it to me again?
So you know how Gabor does, right? That's clear.
Yes.
After externalizing the haptic, he goes very close to the externalized part, making the Gabor tunnel.
Okay.
And then you internalize the haptic into the sclera using the special Gabor forceps again, the Chariot forceps.
Yes.
So the externalization and the internalization, the part is very, very close. And that is why Chariot technique did not become very popular. And that is where glued became popular. Yes. Because you made a flap and you are entering it away from the externalization and you are closing the sclera with the flap.
Yeah.
So now Prabu is making the Chariot tunnel simple. So the externalized haptic, so you don't have to make a track before and keep it ready for internalizing the haptic inside. And that is the most difficult step. And the other thing is the Chariot forceps is also expensive. Any micro forceps is expensive, and within 10-12 cases, it also gets damaged.
Yes.
Because I've seen every other day our retina surgeons coming for a new Chariot forceps. That is where it really gets damaged. And then sometimes they don't internalize properly. Sometimes the haptic is exposed. And this is the question which Prabu kept asking him and several other doctors, and they said they need a simple way to do it. And this is where this haptic insertion into the polyamide tube and then taking the suture bite close to the externalized area is now helping you as a whole. So I think Prabu will share you the video. Once you see that 2-3 times, I'm sure you will definitely pick up that.
Yeah, now I got the point. Yes.
That small step, incremental step, which he has done to make it simple. Prabu, one simple thing is, at the end, if you have a long haptic, you can also think of just flanging it.
Yes, sir. Or you can also trim it, sir. You can trim it also.
Yeah, you can trim it. You can just flange it and push it.
So you don't have to always push it back.
Yeah, you just need a low cautery.
Just a Yamane technique.
If I can just add, actually, what I think Prabhu, actually what Prabhu's technique is doing is when you bring out the haptic externalized, to again push it through an intrascleral tunnel, you will bend the haptic. So that is the catch. What he's doing is he's giving you a continuous track and he's allowing the haptic, he's pushing the polyamide tube along with the haptic back into the eye. And then he's getting it back into the track. So it's moving in a single action, in a single pass. It's going into the tract.
Exactly.
And that's very close to the scleral port where it's coming out. So it's a kind of continuum.
Yes, sir. True.
So the haptic stays with the polyamide tube. Am I right?
Not at the end of surgery, it will come out. At the end of surgery.
No, polyamide is part of the device that will come out, sir. It will not stay inside.
It's polyamide is only railroading. It's railroading.
Railroading, and once the haptic goes in, the polyamide is removed.
Yeah, it's just pulled out. It's just pulled out. No, it just stays there. The haptic stays and the polyamide comes out.
Very good. Excellent.